Hello ladies and gentlemen, my name is Dr. Novoa. I'm a cosmetic OBGYN practicing in El Paso, Texas. Today I will discuss what I consider a more effective and safer way to remove the Nexplanon when the implant is in a suboptimal position. For those of us that routinely remove the Nexplanon, the implant is often found in a position distal to the original point of insertion, making it difficult to feel and difficult to remove. In many cases, the device is deeply embedded in the subcutaneous tissue rather than subdermal and is difficult to manipulate. Most instructional videos demonstrate how to remove the Nexplanon when located in a subdermal position called the pop-out method. Using the pop-out method, the Nexplanon is palpated and pressure is placed on its proximal end, which lifts the distal end of the implant, allowing a bulge to appear against the skin. An incision is then made at the bulge, opening the implant capsule and allowing the distal tip to project through the incision for easy removal. The pop-out method, however, is difficult or impossible to use when the implant is much deeper in the subcutaneous tissue, scarred in position, or non-mobile. More importantly, many videos demonstrate blind dissection to reach the implant, which significantly increases the risk of unintentional damage to underlying sensitive structures such as nerves, blood vessels, or the bicep or tricep muscles. Today I will demonstrate what I consider to be a better option than the pop-out method for implant removal, especially when the Nexplanon is difficult to feel below a subdermal plane. This technique is called the Implant Grasping technique, or the IG technique. The IG technique can be a significantly safer method for implant removal when the device is difficult to palpate, non-mobile, or close to sensitive vasculature. I hope you enjoy the presentation. Nexplanon is a long-acting reversible contraceptive placed in the arm. It is highly effective with less than 1 pregnancy per 100 women who use it for 1 year, and it is highly convenient, lasting up to 3 years for pregnancy prevention. Nexplanon should be inserted subdermally and easily palpable after insertion. If unable to palpate, an ultrasound is recommended for confirmation of location. If not palpable, unassisted removal should not be attempted. Nexplanon must be removed by the end of the 3rd year. At time of removal, a new Nexplanon may be placed. Recommended removal based on optimal placement is called the pop-out method. Optimal implant position is defined as a subdermal or subcutaneous placement of the Nexplanon, confirmed position with light or deep palpation, and greater than 1 centimeter superficial to the neurovascular bundle or muscle fascia. Suboptimal implant placement can be defined as an implant that is difficult to palpate, non-palpable, or less than 1 centimeter superficial to the neurovascular bundle or muscle fascia. Improper implant position is defined as an implant within the neurovascular bundle or muscle fascia, below the muscle fascia, within the tricep or bicep muscles, adjacent, bordering, or within the vascular tissue, such as inside of the pulmonary artery. The most commonly used method for the removal of an optimally placed Nexplanon is called the pop-out method. This is appropriate when the Nexplanon is easily palpable, mobile, or can be manipulated so that the distal tip of the implant is bulging against the skin. It is difficult to use this technique in a suboptimal placement. The implant grasping technique, like the pop-out technique, is appropriate for easily palpable, mobile, and bulging distal tip implants. However, it is more effective with suboptimal placement and can stabilize the implant's position and decreases risk of injury to underlying structures as compared to the pop-out technique. When using the implant grasping technique, the patient is prepped and draped in the usual sterile fashion. The implant is then palpated, and the proximal and distal boundaries of the implant are determined. The implant is then held fixed between 2 or 3 fingers. While holding the implant firmly in place, infiltrate 3 to 5 cc's of 1 to 2% lidocaine with epinephrine below the implant. Make an incision either parallel or perpendicular to the implant using a 15 blade. Use a small straight hemostat and grasp the center of the implant. Firmly grasp the lateral edges of the implant held between your fingers. Clamp the implant, preferably mid-length, disrupt the implant capsule, and remove. Confirm the integrity of the implant and its 4 centimeter length. Finally, bandage the patient and apply a pressure dressing to reduce the risk of bruising and the possible development of a hematoma. The arm is prepped and draped in the usual sterile fashion using antiseptics such as Hepiclens and/or betadine. The position of the implant is determined, grasped between 2 to 3 fingers, and the implant is raised up under tension. 3 to 5 cc's of 1 to 2% lidocaine with epinephrine is used to create a wheal and to infiltrate below the implant to provide anesthesia as well as lift the implant. In order to maintain implant position, do not release the implant or tension during infiltration. Make a parallel or perpendicular incision below the implant. Using a small straight hemostat, break the implant capsule and attempt to grasp the implant at its mid-position or 2 centimeters from the distal tip. Do not release tension on the implant while doing this and keep the implant in a fixed position. After removal, secure the wound site with sterile dressing and a pressure dressing. In conclusion, the implant grasping technique is superior to the pop-out technique for deep or suboptimal implant position. Infiltration and implant lifting away from the underlying nerve and vascular structures reduces the risk of inadvertent injury to deeper structures by either sharp or blunt dissection. This concludes my presentation on the IG technique for Nexplanon removal. Thank you very much for watching.